Welcome to We're on ECMO, an educational series for the ECMO community. My very special guest today is Dr. Giles Peek. Dr. Peek is a professor at the UF Health Congenital Heart Center, is a pioneering ECMO surgeon, and author of the game-changing CESAR trial that helped to advance adult ECMO. Dr. Peek, thank you so much for joining me today.
Thank you, Neil.
I know as a cardiothoracic surgeon, you've done your fair share of ECMO cannulations, and of course, cannula selection can impact patient survival. Can you start today by giving us some of your insights to the appropriate cannula selection for VV and VA ECMO patients?
Sure. I would like to completely change the subject, though, to start with.
Okay.
I identify as an ECMologist before I identify as a cardiothoracic surgeon.
Okay.
Now, clearly, being a cardiothoracic surgeon feeds into what I can do as an ECMologist, but I believe that ECMologists exist and that they are far more than either surgeons or intensivists, and that in order to pick which cannula to use, it's not just a case of looking at what the flow rate you want is, but you need to think about the whole patient journey. So you need to think about supporting them adequately, and then being able to mobilize them, and then being able to either bridge to the next device or to decannulate them. So I think that when we sit in our silos as either surgeons or intensivists, I think that we lose some of that ability. And I think that not everybody that looks after an ECMO patient or contributes needs to be an ECMologist, but I think that every team needs to have them. And I think that if you have a team that has a mix of backgrounds in your ECMologists, I think you provide very good care. So I think having people from an intensive care background and a cardiology background and a surgery background, I think gives you a very robust approach to the patient. So thinking about cannula selection, you need to remind yourself of Poiseuille's rule, which is the physical rule that governs flow down a tube. And what it states is that the flow is proportional to the fourth power of the radius divided by the length. So if you halve the length of a cannula, you double the flow rate. If you double the diameter of a cannula, you increase the flow rate by 16. So a small increase in the width of particularly the venous drainage cannula, it can make a massive difference to the amount of flow. So that's the first thing. The second thing I think that people often forget is that the tip of the cannula needs to be in the right place. So if you put the tip in a vessel that's going to collapse, then it's not going to drain very well because the vessel will suck flat. So it doesn't matter how big the vessel is, it's not going to work properly for you. And I recently consulted on a patient that treated in another hospital where they'd a 10-kilo patient, and they put a neonatal venous cannula in the femoral vein and were trying to drain from it. And of course, as soon as they tried to increase the flow, the iliac vein where the tip was sucked flat. So the places that will stay open to a degree are obviously the right atrium and the intrahepatic inferior vena cava, because it's kind of stented open by the liver. So you need to have the tip of your venous drainage cannula in one of those places. And there was recently a paper that showed that if you place the tip of the venous cannula from the femoral vein just inside the right atrium, that you can actually achieve not only a negative fluid balance in your patient, but also increased survival. So it really makes a difference. So that's one aspect. Now, Poiseuille also states that the flow rate is proportional to the pressure drop across or rather the driving pressure. So if you have an arterial cannula, which is obviously being driven at higher pressure, then it can get away with being smaller than the venous cannula, which we of course all know. So I think those are the most important things. One thing I often see in intermediate sized pediatric patients, by which I mean kids in the range from about probably about 6 or 7 kilos up to about 20 kilos, is when you have a 1/4-inch venous line. Now, obviously, neonatal circuits have a 1/4-inch venous line and work just fine. And adult circuits have either a 3/8 or a 1/2-inch venous line and work just fine. But when you're beginning to get a little bit bigger, you often find that the 1/4-inch venous line is actually part of the problem in terms of limiting flow. And several times I've changed out both the venous drainage cannula and the size of the venous drainage tubing, and made a big difference the amount of flow that we can deliver. So I would say those are the main things. I think another misconception is that you can't mobilize people with femoral cannulas, that is clearly not the case. The Swedish group, Karolinska, Pelle Palmer and Bjorn Frekner, taught us that you can mobilize a patient on ECMO, first of all. And secondly, they had never used a double lumen cannula in the neck because it was too expensive. So they mobilized all their patients with femoral cannulas. And as long as they're secured properly and the tip's in the right place, you can do it just fine. And of course, the double lumen cannula in the neck is very convenient. But when you have a mismatch between the size of the cannula and the size of the jugular vein, there's a definite incidence of cerebral venous congestion and neurological injury as a result of that. So putting a venous drainage cannula in the femoral and a smaller return cannula in the neck is a very good way of doing it. Which brings us on to the whole multi-site VV argument. Now, of course, in the old days, before we had double lumen cannulas, we used to drain from the neck and reinfuse in the groin at the University of Leicester. The University of Michigan used to do it the other way around. And they both work just fine. The flow rate that you get when you drain from the neck is higher because you can use a shorter, fatter cannula. And the amount of recirculation when you drain from the groin is lower. So they both have their advantages and disadvantages. And they both work just fine. Now, the standard VV technique now for older children and adults is, I would say, to drain from the groin and reinfuse in the neck. John Lilly and his group at Guy's in London have been exploring multi-site VV even in small babies. Now, they have rediscovered the idea that you can drain from the jugular vein. All of the patients in the CESAR trial were cannulated like that. But the thing that they've done that's revolutionary is they've done it in smaller patients, including newborns. And so draining from the neck and reinfusing in the groin is a very valid technique. I would sound a note of caution in terms of wiring those cannulas and just make sure that the wire is actually in the vessel you think it is, because I'm sure that complications from perforation of the veins and arteries will become more common as this technique becomes more used. So good imaging and good technique is paramount. And that kind of leads on to what should be the standard technique in grown-ups with respiratory failure. And I think that VV is a very good technique, except for patients who have right ventricular failure or are going to develop right ventricular failure. And those patients, people have experienced a lot of success with venopulmonary ECMO, either using a double lumen cannula or, I think more elegantly, using a single lumen return cannula. And my colleague across the street at University of Florida, Mark Maybauer, is published a lot on that, and he's had a lot of success with that technique. And I think it's probably going to become the standard technique. But what I hope is that the danger of using a ventilator is becoming more well known. So I predict that people will use VV ECMO perhaps instead of high ventilator settings, and will use VP ECMO either as a bridge or in patients that are currently the kind of salvage patients. So I think there's still going to be a place for both techniques, but I think there's going to be more and more use of VP ECMO as we go forwards.
Okay. You mentioned, some complications if people aren't careful about when they're placing the cannula and where it's at, and using the image and everything. Can you share some common complications and considerations that besides that people should be thinking
Yeah.
of?
Well, I think the first thing is when you put a big venous cannula in a femoral vessel, is you can cause venous obstruction. I actually had a patient who has lost a leg to that complication in the past. We cannulated the vein on one side and the artery on the other in an adult congenital heart patient. The venous cannulated leg was the one that became ischemic with a compartment syndrome caused by the venous congestion, which is really quite surprising. So, it's not to be sniffed at. It's usually well tolerated, but venous congestion can be a problem. And I think that as multi-site VV cannulation in smaller patients becomes more common, I hope that manufacturers will produce cannulas specifically designed for it. And I'm talking about a shorter 6 French cannula that can be inserted percutaneously, because I think that having to go with 8 French and having to insert it open is clearly limiting the application of the technique. So that's one aspect. The other aspect is if the guide wire is actually outside the vessel. So it's quite easy to actually cannulate the vessel and then poke the guide wire out the side of the vessel so it's in the retroperitoneal space. Usually caused by not using the correct end of the guide wire and not assuring yourself that in 2 planes that the guide wire is in the right place. So obviously, if you push the cannula over that, it's going to punch out the vein, and then if you don't recognize it and hook the ECMO circuit up to it, you're going to drain the heart out through your lovely venous drainage cannula in the neck and reinfuse the patient's circulating volume into the retroperitoneal space. So if that does happen, the first thing to do is to recognize that that's the case, and then transfuse up the venous drainage line to restore the blood pressure, and then clamp the ectopic line, and then get a return cannula in somewhere else. So perhaps switch to VA and go in the carotid artery or in the femoral artery, depending on the size of the patient. And then you have to repair the vessel. And there's a very good approach to the retroperitoneal inferior vena cava and iliac veins called the McEvedy approach, which is done through transverse abdominal incision, and then you can tunnel round and access those vessels and repair them. And it's not something that a lot of people are familiar with, because usually those vessels aren't affected very often. So it's something that you need to find the person in your vascular group that can do that. And unfortunately, I'm quite familiar with that approach. The other thing, and perhaps the worst and most frightening thing, is if you cannulate the vein through the artery. So in other words, you don't realize that you pass the needle through the artery into the vein. You put the wire up, you put a cannula over it, you've got venous pressure, everything is great. And it may be that that line stays in for weeks and then gets wired out for an ECMO cannula, at which point the cannula will cut the femoral artery in half. And there's usually great hemodynamic compromise as a result, and often results in the demise of the patient. And I've, sad to say, also seen that happen, and that's very difficult to get out of. I think that now we have ultrasound guided vessel puncture. It's less likely, but it's still quite possible. And I think if you're wiring out a line that maybe was put in an outside hospital, which was the situation I was involved in, that you basically have a higher index of suspicion. And particularly if the cannula is difficult to push, or if you goes in easily, which this particular cannula did, and then you have immediate hemodynamic collapse, but the venous drainage cannula works fine, then that's probably what's happened. And you know, being aware that that can happen and acting on it quickly will help control the situation, hopefully.
Gotcha. Well, thank you so much, Dr. Peek. I'm thrilled to have an ECMologist like yourself join We're on ECMO, and I know the work that you do in the ECMO space has led to better patient care and outcomes, and so many people in the ECMO community have benefited from your efforts, and so I really appreciate you being with me today. If you're watching today and you have a question you would like to see an expert answer, please email me, Neil, Neil, at ecmoadvantage.com. We'll see you next time.